Thank you very much, Marvin, and thank you for bringing some spirit into the room that we'll hopefully be able to build on. And so I'm just going to provide a few comments associated with the backgrounder that you have. We're going to be going through the agenda today. We're going to have a bit of context setting prior in some opening presentations. Then we're going to be having some sharing of best practices, some examples that have been identified and it's not comprehensive at all, but some examples of some successful engagement activities that have occurred and projects across the country. Then we're going to be taking a bit of a break, and then we're going to be having an interactive dialogue around how we can take some of those lessons to scale up and some initiatives that we might do across Canada to build on particular kind of successes and address some of the barriers to that there exist, either in gaps of knowledge where we don't know what works, but also some areas where we know what works, but we don't seem to be able to kind of implement significant change. But if we could just move on to the next slide presentation. Okay, because we started, and we're the Institute of Health Economics, and there was a backgrounder put forward which looked at the economic impact of diabetes in Indigenous populations in Canada. It's a bit of an overview. I'm sorry, I need to work this, or if you could flip to the next slide. So first of all, declarations of conflict of interest, as we always do. The work that we're doing in this area has been supported through a grant, unrestricted grant from Bollringer Engelheim, and I'll be introducing Mahmood later, but they've been a significant and a very helpful partner in a number of activities that the Institute has done in specific disease areas and policy engagements that we've had nationally to try and address these problems. And the Institute of Health Economics is supported by ongoing funding from Alberta Health and Alberta Health Services, University of Alberta, University of Calgary, Alberta Innovates, as well as we do a lot of projects with Health Canada and other national agencies. And that's who we are. Just next slide. The acknowledgements, we pulled a group of people together who were a bit of an advisory committee for this initiative. And early on in the initiative, we were going to look at the Canadian Diabetes Clinical Practice Guidelines. You're going to show me how to do that? And clinical practice guidelines. And going to look at pick a couple of areas like surveillance or some of the aspects to see what would be the ones that we would work on. And in discussion with our advisory committee, we ended up, individuals said, well, the real key is community engagement and actual co-development from communities in developing of solutions. And so we said, okay, we won't look at a very specific thing about how to kind of survey and monitor our diabetes, although we do have a highlight of a project where I think it's important to identify, before you can do anything about it, knowing who actually does have diabetes and surveillance. But this is a group of people, and they provided advice on the context of how we should begin this conversation and discussion, which is today's event, about trying to frame what might be effective approaches to engage with communities in building their own solutions and some of the barriers which we'll hopefully try and, through our collective efforts, address in a bit of an ongoing program. Next slide. And so and you can read the background more fully, but clearly there is a disproportionately high rates of diabetes in First Nations and Métis populations. There's less information on the Inuit, but certainly from research it had doubled in the period between 2001 and 2006. There's not really good data on the Inuit population, but I think that you can see here in this, the non-Indigenous population, you can see the prevalence of diabetes on the far right, and on reserve First Nations, you can see it's a significant proportion. Okay. So next slide. So there's many associated risk factors, issues with the burden of diabetes, obesity, physical inactivity, And in Indigenous populations, there's striking amount of diabetes that's developed at a younger age, which is particularly alarming. And it's as you would know, the Aboriginal or Indigenous population is the fastest growing population group in the country. So it's a significant portion of our Canadian youth are being faced with a significant problem. And of course, there's increased rates of diabetes-related complications which occur, which result in high costs for the healthcare system. And you can see these outlined here. And it's not managed very well in the primary care setting, either surveillance or complex care management with that. And also, often it significantly comes to people's attention when people have to enter an emergency room. They've gone into crisis and they end up producing their problems that they have with poor management of diabetes occurs in significant number of emergency room visits. The next slide just shows the economic impact, and there's been few studies done, actually. One of the studies was done by Phil Jacobs, who's from the Institute of Health Economics, who's in the room, which was in 2000, was one of the kind of the few studies that was done, and then there was another study done in 2007. But it showed that Phil's study showed that the cost of diabetes was about 1.7 times higher in Indigenous patients with diabetes than non-Indigenous patients. And in addition, costs were 2.7 times higher among Indigenous peoples with diabetes than other Indigenous individuals. And so it's not only that it's Indigenous costs for Indigenous peoples is significantly higher than non-Indigenous peoples. It's actually those with diabetes in Indigenous populations compared to the rest of the people in Indigenous populations who don't have diabetes is significant. It's a major issue and problem. Next slide. And it's important to look at, and we realize that, and that's part of the discussion today, context is significantly important, and there's a mix of socioeconomic deficits complicated by historical and ongoing cultural, social, political, and economic factors which perpetuate the social and health inequalities for Indigenous people. So you can't look at it in isolation from the context in which people live their lives, day-to-day lives. Now, you do have to try and grapple with something that's handleable and manageable. So when we had this debate and discussion as we dealt with the advisory committee, we can't solve all the problems associated with the socioeconomic circumstances of Indigenous people. But we have to place our efforts to try and improve diabetes care and management within that context, or it won't be successful. And that's why it's got to start bottom up from communities in defining their own solutions to problems and addressing and engaging communities in those solutions. Next slide. And so this is just a great quote, which I won't read, but from Rice et al., which talked about this whole issue of context and local engagement, and how we have to understand that in order to address these problems. And this is unlike a lot of other common approaches where you end up having the very strict disease pathway and you're going to address part 3 in the disease pathway and you deal with it. We have to really try and look at the day-to-day circumstances in which people live in and learn from the local communities about how to address a particular problem, not necessarily coming down and informing what best practice is. Best practice has to be contextualized and co-developed. But I encourage people to read the Backgrounder, and we'll be doing a follow-up report to this event.